We want to spend £450 million to improve acute hospital and maternity services in Leicester, Leicestershire and Rutland. This means the services provided at the Leicester Royal Infirmary, Glenfield Hospital and the General Hospital. We want to see improved patient care, better patient outcomes and have staff working in the best place to make this happen. Most of all, we want to deliver hospital healthcare that is fit for the future. This is your chance to find out more about what is being proposed and to have your say. This will help your local NHS understand what the changes would mean for you and help us make a final decision.
What we don't want is a health service that's designed only by the people who work in it. It's got to be designed by the people who experience it and use those services.
The proposals include 2 super intensive care units, one at Leicester Royal and one at Glenfield Hospital, with 100 beds in total. That's almost double the current number. Modernised wards, operating theatres and imaging facilities. The first dedicated single-site children's hospital in the East Midlands, based at the Royal. And a new maternity hospital. Currently there are 2 units on different sites, the General and the Royal.
Obviously having 2 sites means that sometimes we're spread too thinly. When we're really busy, when we haven't got enough rooms or when we haven't got enough staff to look after the women, especially in labour, women need one-to-one care. We have to transfer activity from one site to another. So we would envisage that with a new larger hospital where we've pooled the staff together, that likelihood would happen less often. The beauty of it is that they're going to be in one unit, and if there is an emergency situation, they can very quickly have access to the obstetricians and the neonatologists.
Under our proposals, Glenfield Hospital will become a major planned care treatment centre, with welcome centres to put you at ease and help you find your way around the hospital. These changes would enable us to separate emergency care and planned operations. This would help prevent treatment being delayed or cancelled when the emergency services are busy. More than 100,000 day case procedures and around 600,000 follow-up appointments take place every year at the city's hospitals. The move will free up capacity at the Leicester Royal Infirmary and help ease issues of access and parking there.
Let's take a patient, for example, who's having a planned day case surgical procedure. They will receive their pre-operative workup on this site, so all the tests and things they need doing before the operation. They will have also been seen in clinic on this site to have the decision made that they need an operation in the first place. Then they'll come to this site, they'll have their operation and go home the same day, and any follow-up that's necessary after that will also be provided on this site.
Leicester General Hospital will become a community health campus. It would include facilities such as the Diabetes Centre of Excellence, a dedicated imaging hub to help GPs diagnose patients' conditions quicker, and a stroke recovery service with inpatient beds. It would potentially be home to a midwifery-led unit, which will be relocated from St Mary's in Melton Mowbray. This will make it accessible to more people and provide a better and safer experience for mums. Today's modern medicine and technology means many patients don't always need to stay in hospital to get well.
Over the last 30 years, the NHS has cut its beds by about 50%, which feels counterintuitive looking at the population growth. But when you take into consideration the change in medical practice over 30 years, so hip replacements used to come in and be in hospital for over a week. They're now staying in hospital for around 2 days. We've got sort of robotic surgery now and keyhole surgery, which means patients don't stay in hospital as long. And we used to prescribe bed rest for patients. We don't do that anymore either.
And for some conditions, you can be cared for at home or where you live.
If you need to be in hospital, so you need treatment or you need investigations that can't be done in the community, or for instance, you're acutely unwell and you need the investigations doing straight away, hospital is the right place for patients. But there's certainly patients where their medical treatment can happen at home, and it's much nicer for the patient if you can have all the care investigations done in your own surroundings, done at local community hospitals with doctors, nurses coming in that will be the same faces that they see on a daily basis. It's about having safe care, but in the best way for the patient, the most suitable way.
At At the moment, our hospitals and our staff, while doing their best, are spread too thinly, trying to provide 21st century services in outdated buildings with limited resources and opportunities for change. We want to achieve a service based on our future healthcare needs, not the legacy of the past.
Leicester's hospitals merged in 2000, and whilst that merger was very successful, it left one issue unresolved. And that was that many of our clinical services, the location of those clinical services is more a product of accident than design. They're split across more than one site. Our staff are spread thinly and our equipment isn't always in the right place. And that can lead to difficulties with staffing our services in the way that we would want to do optimally. I'm really excited by these changes. I think that this is a once-in-a-generation chance to provide care in Leicester, Leicestershire and Rutland that will be state-of-the-art, will give patients a much improved patient experience, give them access to modern medicines, modern treatments in modern buildings. And I'm really excited by this, and I hope that people will be when they see the plans of what we're planning to try and do for Leicester, Leicestershire and Rutland.
You can see the proposals on our website and fill in a questionnaire to give us your views.
Thank you for joining us, everybody, members of the public and colleagues. My name is Caroline Trevithick. I'm the Executive Director of Nursing Quality and Performance for the Leicester, Leicestershire and Rutland CCGs. I'm here this evening with colleagues of mine from the Acute Trust. I'll do a bit of a roll call, but people will introduce themselves as they talk, I'm sure. So we've got Ian Scudamore, who's a consultant obstetrician at UHL, Andrew Furlong, you saw Andrew in the video, he's the medical director at UHL, Elaine Broughton, who's head of midwifery at UHL, and Darren Kerr, who's the director of estates at UHL. There are other colleagues who we may draw in the Q&A session, but I'm kind of keen to introduce some of the key players this evening. So welcome. I hope you enjoyed the video. If you didn't get the chance to see the video properly, we will have access to that on our website, so you'll be able to have a look at that at leisure. I just wanted to let you know we're recording this evening, so it helps us replay this for other people who aren't able to join, and they can hear the discussion and understand the question and answers. So what we want to talk to you about tonight is the plans to invest the huge £450 million investment that we've had into our hospitals, into Leicester, Leicestershire and Rutland. And the video has given you a bit of a flavour of what we're proposing, but we want to really focus down tonight on what's happening for maternity services. I'm going to hand over to Ian Scudamore in just a minute, but just so that you know the process, Ian's going to go through a few slides to go through the detail, and then we've got the real opportunity for you to put your questions to us. I see that some people have already started to use the chat, and that's a really good place to put your questions, so pop them in the chat. But you will be able to raise your hand and do that. And I'm also conscious we've got people on the phone, so we will come to you on the phone for questions as well. So if I can hand over now to Ian. I'm just checking we haven't got a problem with the slides. Yeah, perfect.
No problem with the slides?
Just so that you know, I can't see any slides.
Okay, well I can, Caroline.
Okay.
So the first one's come up, so I presume you've got control of them, have you? Somebody must have control.
I do, Ian, it's fine.
Okay. Right, so thanks very much, Caroline. I'm Ian Scudamore. Some of you may know me because I've been here in Leicester for some time now, and so I've seen quite a lot of people during my career since coming to Leicester in 1997. Now, I think it's worth just having some historical context here. I mean, this slide gives you a clear idea of what we're planning to do, but I think it's worth just putting it in a little bit of context, and we do have an hour and a half, and I think it's important to understand the detail. When I came to Leicester in '97, there were two units, two completely separate trusts at Leicester General and the Leicester Royal Infirmary. And they worked independently, and they both provided comprehensive services with comprehensive maternity services, including level 3 neonatal intensive care units on both sites. In the early part of the noughties, it became very clear that it wasn't possible for us to sustain 2 level 3 neonatal units. And that was very largely because of staffing issues, medical staff, but also nursing staff. And it wasn't safe to continue to provide neonatal intensive care across the two sites. And so the neonatal service at Leicester General was reduced to what's called a level 1 special care baby unit. And what that means is that since about 2004 or 5, we've had to do, as far as possible, we've had to deliver babies at the Royal Infirmary that we anticipate are likely to need longer term neonatal intensive care. Now that's an example of a problem that is liable to be created by having to provide complicated services across two sites. It was the first example where we had to actually make a significant change because we weren't going to be able to sustain two services. We carried out a very broad ranging option appraisal in the early part of the noughties with regard to maternity services overall in Leicester, because it was recognised that they weren't really sustainable for the longer term. And that was part of the Pathway project. And the conclusion from the Pathway project was that really, in order to make them sustainable for the long term, they needed to be, maternity services needed to be co-located on one site. And at that time, it was expected that that would be actually on the Glenfield site. Pathway didn't go ahead for reasons that most people will be aware of. And then there was a second review, again, broad-ranging review that was sponsored by the PCT at the time, 2009-10. Which was called the Next Stage Review and was post Lord Darcy's recommendations. And again, there was a very wide-ranging option appraisal with very wide consultation and engagement with stakeholders, including the public. And once again, the conclusion very clearly, having looked at all the different options, including 2 sites, 3 sites, a single site, and different locations for that single site, the conclusion was that there needed to be a single co-located maternity service, and that the most appropriate site was the Leicester Royal Infirmary. And the reason for that was that even then, that's where the most important services to support maternity services were located. So, for example, general medicine, general surgery, all the laboratory services, intensive care facilities, pediatrics, the ability to use the neonatal intensive care service effectively, etc. That wasn't possible to do at the time because of funding, and so we then had to wait for a considerable period of time, and we put quite a lot of money into what was called some interim mitigation to try and make sure, well, to ensure that services were safe across both sites, the Royal Infirmary and Leicester General. And that has been successful in being able to sustain services until this time. But it is the case that our ability to provide safe services on both sites is challenged, and it's challenged quite frequently. And we do have to make compromises in order to be able to look after the women, and that's not always it's not always possible for us to look after with them in the way that we would like to, from the perspective of providing things like one-to-one care and being able to offer them the services in a timely way that quite reasonably they should expect. And so we then did a third review of the 2 previous reviews, and we took that through the regional senate, clinical senate, and we were challenged quite strongly by the regional clinical senate with regard to the plans, because everybody recognises that there are compromises in co-locating services and moving the maternity off Leicester General and doing the reconfiguration in the way that is planned. And the regional senate understood and agreed with both of the previous reviews, and agreed that we were pursuing the right plans in the circumstances. And so that's why we've got to where we are now. And essentially, the plans that we've put together will create a dedicated maternity hospital at the Royal Infirmary. And that will be co-located with all the important services that are necessary to provide the kind of care to the stakeholder group, the women that we look after. That care, we recognise, will be in a very big new build, and we will work assiduously, and we're very conscious that we need to make sure that we give personalised care with a named midwife. And so we're engaging very actively with the Better Births agenda and national maternity transformation to ensure we do that. There'll be an obstetric unit, which I like to call a combined care unit, which is staffed by midwives and doctors, and that will be co-located with the neonatal services. There'll be access to a hospital midwife-led birth centre, so the birth centre will be in the same building, and there will be ready access to the obstetric unit should somebody need that and need medical support, whether that be for obstetric reasons, anaesthetic reasons, or indeed for neonatal reasons. We're going to develop a 14-bed transitional baby care facility for mums whose babies can't go home yet but don't need significant neonatal intensive care or special care baby attention. And there will be proper facilities to support partners staying overnight instead of, as it is the case at the moment, which is very ad hoc and not very comfortable for partners when they do need to stay. And clearly there'll be access to the neonatal intensive care. Can I have the next slide, please? What we think is important, I mean, the model of care is primarily going to involve nearly all of our, essentially all of our normal routine antenatal care being provided in the community by our community midwives. We will be providing antenatal care in the hospital for more complicated pregnancies, such as women with diabetes or kidney disease or high blood pressure or other problems. And there will be hospital-based antenatal services, including a fetal medicine service and a daycare unit and a variety of other things. But when it comes to birth, we do want to be able to provide all 4 options for women to choose to actually have their baby born. Clearly, I've already described the obstetric unit, which is combined midwifery and obstetric care, and also the alongside birth centre, which is staffed by midwives, not by doctors. And so all the care would be provided by midwives, and only in circumstances where there were complications would the woman need to be transferred into the obstetric unit. But we also want to be able to provide the community-based midwifery-led services. And essentially, those are much the same, insofar as there isn't any medical support in either of those settings, which are home birth and a standalone midwifery unit. Now, some women would prefer to have their babies in the community at home if they're low risk and they're suitable for that environment. Others, although it isn't materially any different, would prefer to go to a standalone midwifery unit. And in those circumstances, we think that it's very important that we maximise equity of access for all the women of Leicester, Leicestershire and Rutland. It's also the case that a midwifery unit of that kind needs to be doing about 500 births a year for it to be financially sustainable. And so we think that the Leicester General Hospital base is the most appropriate site for that type of unit, partly because it provides equity of access and more women will be able to consider it as an option for them to have their baby. And secondly, because it gives us the best chance of having enough births to make it a long-term sustainable option. Unfortunately, that means that the standalone unit at St Mary's is not going to be able to be continued because we can't run 2 standalone midwifery units. It's not feasible. And unfortunately, at the moment, the St Mary's unit in Melton doesn't do enough births to make it a sustainable long-term service. We recognise that it's very, very important that we have proper community-based services and support, and so we're expecting to develop community-based hubs which would help with the antenatal care that we can provide, but also crucially postnatal care and support services such as other baby care support. The next slide, please. So I think that's really what we wanted to talk about from the point of view, or set the scene from the point of view of the plans for maternity services. But Elaine certainly has the detailed understanding of her midwifery team, and she and I, between us and anybody else who's on this call from UHL, will be very happy to answer any questions that you have in relation to the plans that I've just described.
Thank you very much, Ian. And we do have questions coming in the chat, so that's good. So I'm going to start with the questions in the chat because no one's got their hand up. But please put your hands up if you want to, and I'll keep an eye on that and come to you. I think the first question that we've got in the chat, challenging my eyesight here because it's tiny, from Glyn Cartwright was, what's the geographic catchment area for St Mary's Birthing Centre?
So the geographical catchment area is the northeastern part of Leicestershire and the southern part of Nottinghamshire, essentially. There are something around 1,800 women a year that live in the Melton postcode and the adjacent postcodes and book for maternity care. So less than 10% of them end up having their baby at Melton. Now, the transfer rate during pregnancy is something around 40% or so. So there are likely to be around 300 women a year that would quite like to have their baby at Melton, of whom 170 have done in the last 12 months. So that's less than or around 25% of the women who, well, even less than that, it's about a sixth. So it's less than 20% of women who might choose to go to St Mary's actually choose to do so.
Okay, thank you, Ian, for that. Glenn, another, I think we've got a bit of a few from yourself. I'm not sure if you want to ask the questions yourself or you're happy for me to read them out. I'll keep going then. So the second question was around the meeting that was held by Melton Council. I think it was last week that we were invited to. A question as to whether or not we've got the responses captured from that meeting. It was a meeting held by the council, so that was recorded, so they should have it. But in terms of accessing our notes, I think we're just working on that. I don't know whether any of the comms team is able to answer that yet. If we can put that in the chat, that would be helpful. So next question is from Kerry Motor Stubbs.
Yeah, so I've just, if I just comment on that, and then Elaine, I think Elaine might want to contribute on this one as well. I think what I would say is that we're very committed to better births and maternity transformation. Now, a major part of the model for maternity transformation is continuity of carer and making sure that women from disadvantaged groups and women who are also potentially low risk have the options to birth in environments where they want to, with a team of midwives that they know. Now, in that context, I think that the proposal to have a standalone birth centre on the Leicester General Hospital site is a really, really positive opportunity to develop a model for midwifery-led care, which I think would be nationally recognisable as being different and something as an exemplar. But it is dependent on people wanting to do it, and women wanting to have their babies there. So what we would be expecting would be to use the expertise of the midwives at Melton, to use the expertise of our community midwifery teams, to work with Elaine, and I'd be very grateful for Elaine's comments in a minute, to promote a centre at the General, and hopefully it would be popular and it would be actively used. Now, the reality is that if after 12 months it's not popular and women actually are deciding that they don't want to go there and there aren't very many deliveries and women's preference is either to stay at home or go to the alongside birth centre at the Royal, or indeed to deliver in the obstetric unit at the Royal, then if it's not a sustainable option for the long term, I think it might not be something that would continue. But there is no intention to set it up to fail, and there is no intention to undermine it and prevent it from being something that should be successful.
Okay, thank you. Elaine, is there anything you want to add to that?
I wanted to reiterate the commitment that, I mean, I am a midwife, so I am committed to midwifery-led care. And a birth centre, standalone birth centre, is a choice that we still want to offer women. We just want to offer it to more women across LLR, make it a bit more centralised to give everybody that chance to use it and be able to choose. And our midwives are dedicated to providing midwifery-led care, and this is an ideal setting. So we really, really want to make this work, I can assure you. As a midwife especially, I want to give you that assurance.
Thanks, Elaine. Okay, I'm going to keep going with the messages as we've got. Glyn, you've asked a question around how many births have there been from the St Mary's Birthing Centre catchment area over the last 12 months, and asking for them broken down. Ian, I wonder if you can see that. How many were at the birthing centre, how many were home? So it's quite a lot of detail being asked for there. Okay.
Yeah, and if you want very accurate numbers, we'd have to look them out for you, Glyn. But there were 170 deliveries at St Mary's Birth Centre, which was a little bit better than the previous 12 months. And that was probably contributed to some degree by COVID. In terms of home births, Elaine, I don't know the numbers of home births for the St Mary's catchment. Have you got any idea? It would be something between 2 and 3%. And there was something of an augmentation again during the COVID crisis earlier in the year, when women chose to have their babies at home rather than going to hospital. The rest would have been distributed between the Royal Infirmary, the General and the Nottingham hospitals. And I can't tell you what proportion were to at-risk mothers. What we do know is that when we did a very wide consultation or engagement exercise that I referred to with the Darcy Next Stage Review, there was a very clear preference and priority for the general population to be able, if they were going to have their baby in a low risk environment, to do it in an alongside birth centre where they still had access to medical support if they needed it, rather than to require transfer. And so that's one of the reasons it's very important for us to develop that model properly, so that people who are in the majority of people that want the low risk environment will have access to it. And that's illustrated, in fact, just by it's very anecdotal, but by a patient I saw today, who's had 2 or 3 babies before. In fact, has had one in Nottingham, one in Leicester, and one in St Mary's, and is later in her pregnancy. And I said to her, you don't have to come to one of the 2 hospitals. You can certainly have your baby at St Mary's if you like. It would be perfectly reasonable. She said, no, I really don't want that. I want to be able to have access to medical support should that be necessary, but I'm very happy to have the baby in the birth centre. So I think it's difficult to give you specific numbers. If you want them, we can find them, but we'd have to have a think about what the actual catchment area really is. We'll move to Glyn's next question. You've already decided to close Milton. Did that years ago. The funding agreement with the government is based on closing Milton, isn't it? Well, I can just say no, we haven't. We've given an undertaking that it will stay open until these plans are executed. We didn't decide to close it years ago. It is a service which in fact is inequitable, but we've sustained that because it's something that's important to the local population. And we've continued to support St Mary's despite that, and would do so, but for the fact that actually we need to reconfigure in the way that's described, and the funding agreement with the government is not based on closing Melton at all.
Thank you. I'm conscious that Elizabeth Warren, you've had your hand up for a little bit, and there are a number of questions. I don't know when we'll come to you, so I'm going to bring you in now, Elizabeth. It'd be good to hear from somebody other than me and Ian. I can't hear you, Elizabeth, if you're speaking. I'm not sure if you're muted.
Can you hear me?
I can, yes, yes. Oh, welcome.
I'm afraid I found it very difficult to hear what has been said. So forgive me if I go over something. But I believe you said that it's only possible to have one midwife-led unit, and it seems to me that if that is at the general, and it's only given a year as a trial, it's almost bound to fail, because mothers, I've seen it pointed out in documentation by somebody else, that if mothers feel that if they're expecting babies and they think, oh, the unit might not be open when my baby is due, they're not going to sign up to the idea of going to a midwife-led unit in case it's closed by the time they're having their baby. So if you're going to actually have a midwife-led unit, it's got to have the full support. It's got to be able to be built up. It's got to go on for a lot longer than a year. It seems to me that I'm 81 years of age, so I'm not expecting to be having this service, but it seems to me that midwife-led units are by far the better way for women to go. And I've been impressed by the research that I've read on this subject, and I wonder whether you have read the research on the subject. The midwife-led units are much more successful when they are standalone, and they're much more successful and cheaper than mammoth hospitals, mega maternity hospitals. And I wonder whether, first of all, whether you've seen the research, secondly, how you can possibly imagine that it can be a successful experiment, trial for just 1 year. If you do have it for 1 year, you're going to have to put a lot of money into it. And if you abandon it after a year, all that money will be wasted. Either that, or you're not really seriously going to put much money and effort into it, in which case it's a bit of a charade. And I really feel you should be thinking about a scaled down hospital on the infirmary and 2 midwife-led units, keeping the one open in Melton and having one at the general if that's the right place, or maybe the other way around, the scaled down infirmary, the scaled down maternity hospital on the general site and a midwife-led unit at the infirmary site. But there needs to be at least 2, and I would like to think in the future more midwife-led units, it seems to me.
Thank you, Elizabeth. Ian, do you want to respond to that? I know I acknowledge we've responded to a similar question, but Elizabeth said she didn't hear.
Okay, so I think, thanks, Elizabeth. When we did the next stage review, one of the options that we looked at was having multiple midwifery-led community-based birth centres around the county, and we looked at having one in the northeast, one in the northwest, one in the southwest, and one in the southeast, and actually one in the centre. And Melthwaites was involved. Melthwaites is on this call as well. Melthwaites was involved with this with me at the time, and we did some quite extensive research about whether that was realistic, and looked at the financial modelling. You know, I mean, finances are not the driver for this, but we have to be realistic, and there is a limited purse available for us to be providing our services. And it was clearly not going to be feasible to have multiple standalone midwifery units around the county, because it is the case that you have to get to about 400 or 500. Yes, you're right. It is cheaper to run a midwifery birth centre once you get to a certain critical mass. But at the moment, A birth at Melton costs us twice as much as a birth at the Royal Infirmary or the General. Now, that's something that at the moment we're supporting because it's valuable to the community. It is an important service. But in the longer term, that's not realistic when there is going to be a standalone birth centre alternative on the LGH site. Now, it is very interesting to hear your comments about keeping it open for 12 months and issues around whether women will book there or not on the basis of uncertainty as to whether it will be open or not. And I think that's something we'll have to think about in our planning and how we might plan for it. We won't have to spend a lot of money on the service on a standalone birth centre at Leicester General because there's already a unit there. There's already a birthing unit, a maternity unit there. So we will be able to use that with minimal capital expenditure. Now, if after 12 months we believe that it's got legs and has a realistic chance of long-term sustainability, at that point we would be in a position to spend money on it, should that be necessary. But I don't think we'd be expecting that there would have to be 500 deliveries there in the first year. But I think we'd have to be able to demonstrate that there's a very clear appetite for having babies in that environment. Now, the best research that's available about standalone midwifery units and place of birth is the birthplace study, and that's largely about safety and success in terms of outcomes. And it's very clear that appropriately selected women are as safe to deliver in a standalone birth centre or at home as they are in an obstetric unit or alongside birthing unit, unless it's their first pregnancy and they need transfer in labour. Provided that they don't need transfer in labour, and around 20% of the women in a standalone birth centre do, then their outcomes are as good, or as you say, potentially better, because there's less risk of interference from meddling obstetricians. But nevertheless, if they need transfer, then the perinatal morbidity and the outcomes for the babies is significantly worse. And that's the best available research.
Thanks, Ian. I'm going to go back to the questions in the chat. We've got one from Catherine Jones that's picking up a safety issue, but more a safety issue from if we put everything onto one site, are we actually going to be struggling if there's a fire or another pandemic? And a question as to whether or not St Mary's took patients from our acute sites during the first wave of COVID. Ian or Elaine?
Elaine?
Well, I can answer the bit about St Mary's taking additional cases during COVID. During the month of May, the figures, I think St Mary's took about 10 more. They had about 10 more deliveries that month than they do normally. And then after that, the figures settled to sort of between 9 and 12 a month. And there was about 24 in May, I believe. So that was the biggest month. So after that, we opened our birth centres, our alongside birth centres again, and the numbers dropped at St Mary's. About the pandemic, obviously, the new build is going to be made so that we've got lots of room for isolation, a lot more room for social distancing, and a lot more ensuite facilities so that we can isolate women in case of not just sort of COVID pandemic, but any other infections, hospital acquired infections. And then safety in relation to putting all the deliveries on one site. In relation to fire, obviously we have very strict fire regulations, and I'm sure Darren could come in on the fire regulations, but in relation to safety putting the services on one site, I mean, we have to think about the neonatal unit and the babies that are born at the General currently that are at risk being born at the General, having two sites, because we've only got sort of a level 1 unit for babies over 32 weeks at the General, and very sick babies need to be transferred to the Royal from the General. And so we've got to think of the babies as well as the mums in the way of putting women all on one site and having, you know, the births there. And plus the staffing can be much more well utilised all in one place. We're spreading the staffing across 2 sites, plus at St Mary's and all over the community at the moment. Nationally, there's a shortage of 3,000 midwives, and although we have opened 2 universities are now supplying us with qualified midwives, we're still a long way from getting to the number of midwives we need, you know, to be able to spread our services thinly across all the sites we've got. I don't know if Ian wants to come in and add any more. I don't know if I've answered everything there.
I think you've done very nicely.
Okay, let's get going because we've got loads of questions
Okay.
in the chat. So Helen Cliff has asked why we're not moving the postnatal ward alongside the midwifery standalone unit. She feels there's a reduction in patient choice for pregnant women, not just about relocation. And a comment that you can't replicate that kind of postnatal care, I think she's talking about, in the community. Many mums value an inpatient ward for 1 or 2 nights wherever they give birth. So I think this is, Elaine, that's probably one for you in terms of that postnatal support for mums.
So if we open a birth centre at the General, we will be having the ability to keep women not on a postnatal ward as such, but we will have like rooms that the women can stay for longer than a period of 4 to 6 hours, and hopefully up to 24 hours, just to, you know, make sure mum and baby are okay and they're happy with feeding. The whole ethos of Better Birth, the National Maternity Review, was that women had their postnatal care closer to home and continuity of carer. So hopefully the midwife will have got all the continuity of carer pathways running by then. So the midwives will be going into the birth centres with their own women. The women will know these midwives, and the midwives will forward them home and provide the postnatal care. And it's been shown that if the woman knows the midwife looking after her, then she has much more confidence and ability and the confidence to, you know, go home in her own environment with somebody she knows caring for her and going home to visit her. Plus, we will have a robust system of training MSWs, maternity support workers, that will be able to also provide support in the community.
Okay, thank you. Thanks for that, Elaine. Carol Hopkinson has asked a question, just talking about the fact that the 500 births is a monetary-based target and not a consideration of what the women in St Mary's Centre have said is their desired option. Travelling to the Royal is undesirable for women in the throes of contractions. And why is Melton not being considered as the best option for women in Melton? I think Ian has covered the points about equity across the whole of LLR, and that's what we're trying to do. But also in the fact that mothers in Melton aren't picking up the option of Melton Birthing Centre. So unless Ian, have you got anything to add?
Yeah, I think, Caroline, the other thing is that if Melton is best for Melton women, then Melton will still be available, because women will be supported to have their babies at home should they want to stay in Melton. And there is no material difference between them having their baby at home and going to the birth centre. It's as safe. They will get the same midwifery support. If they do want to go to a standalone birth centre, they'll certainly have the option of going to the one on the LGH site, or alternatively, if they prefer, they'll be able to go into the LRI. So, you know, they will still have the option of having services provided to them locally in Melton.
Yeah, thank you, Ian. Okay, Becca, you've put a question in about travel. We've previously stated that the north-northeast area would be least likely to benefit from the proposals. And we've stated that for 30% of people, travel times would increase. Surely this isn't equity of access. Surely this is a loss for those people. And you're interested to know where the statistics have come from. Have we got Jason on? Jason, did you want to come in and respond to the question about travel? and how we're doing some work to really explore the impact of travel on the whole of the population.
Yeah, I can do, Caroline.
Thanks, Justin.
Hello, everyone. I'm Justin Hammond. I'm
Oh,
the.
sorry,
It's
Justin.
okay.
Renamed
Justin
you.
Hammond. I'm the head of the Reconfiguration Program Management Office. So the work that we've been doing around travel when the pre-consultation business case was first written back in 2018 used data that we had available to us at the time, which we then used as a modelling tool. So this wasn't an accurate per postcode per area, but it gave us an idea of when we move services between the general hospital site over to the Leicester Royal or over to the Glenfield site, what the impact of any particular postcode area might be. And that gave us basically some modelling that said approximately 30% of people, patients that would be going to those two services that moved across would be adversely affected. And by that, we just meant that there would be additional travel time. It certainly wasn't meant to be that then that was that we would try and do everything that we possibly could to make sure that we don't move the services. It was rather that then we had to turn that into a transport consideration that said what other ways could we enable patients to move easily and what things did we need to consider. So any of the information in the pre-consultation business case is around modelling rather than specifics. We've now got a company called Go Travel Solutions, and this company are working with us and working with patients and the public and the health watches and other community groups to then redefine the travel into a proper travel action plan. So on the website now, on the consultation website, there is our overarching travel plan, which is a very detailed document which talks about all the different types of travel for the sites. And what Go Travel Solutions are now doing is basically turning that information, listening to the outcomes of the consultation, working with groups to then deliver a detailed travel action plan to really look at what will work for each area and how things can be improved. And that's more than just parking and more than just travel by car. That's looking at bus routes and electrification of buses, park and ride, all sorts of different things. So it's a very robust, detailed travel action plans that are being put together now, but they are working with groups, as we say, and that will go beyond the end of consultation on the 21st of December. That will take us into the new year and beyond. I hope that answers it, Caroline.
From you, Caroline.
I'm sorry, I'm talking to myself here. Thanks, Justin. Helen Cliff's also put a comment in the chat about how long it takes to get from Oakham to the General on a match day, and that's the kind of thing that the travel survey will pick up. Helen, you've put in a question about what specific steps do we take to promote St Mary's, as mums don't know it exists, so how can we encourage women to use the new one? So who am I looking at here? Probably Elaine for this one in terms of what we do in antenatal to support choice.
Yeah, so we've had this question actually many times to say that we don't promote St Mary's. So we have tried our best over the past couple of years. It's the first one that pops up, well, it used to be the first one, COVID pops up now on the Leicester maternity website and the information. And there's actually a video of St Mary's that the midwives have done out there. It's offered in the handheld notes, the maternity handheld notes that every woman gets when she goes to a first scan. You know, it's in there. So it's promoted as much as any of the other services. And I've just seen a note pop up with capital letters saying that we do not promote St Mary's. It is promoted as equally as any other of our maternity services. It's got equal footing, you know, as I said on the website. And I'm not sure how else you would, you know, if you've got any suggestions about how else we could promote it, that would be really useful. And the website, just seen something pop up. It's actually the Leicester maternity.nhs website, not the UHL website. It's a specific maternity website that we promote it on.
Okay, thanks Elaine for that. I'm just scrolling through the chat.
Yeah, just have a look. There's a lot popping up.
Yeah, there is. There's a comment from Becca has put, if we are promoting it, but we're saying that it's the same as a home birth, when a hospital provides a different offer for women that's cleaner, more sanitised than a home, are we frightening people away from the St Mary's birthing unit? I think what we're saying to women, it's that from a safety perspective for mum and baby, that it's the same safety aspect. But from what Elaine is saying, you know, we do promote it with mums to think about it as a different opportunity for them. Okay, Jack has put a comment in the post. Appreciate people are passionate about St Mary's Birth Unit, but feel a more centrally located unit would allow more mums to take advantage of a unit. Jack's partner and him live in Hinckley, and it would be totally impractical for us to opt for St Mary's, and a midwife left unit needs to be available to as many families as possible, just the one in area of Leicester. Thank you for that, Jack. That really does kind of illustrate why we're trying to look at it from an equity perspective. Helen Cliff has put another comment in. Why not expand St Mary's instead of closing it, in order to support rural maternity services rather than focus all resources inside the city, and it would help reduce traffic congestion and carbon footprint as well. I think that's probably back to Jack's comment actually about the fact that the more centralised service allows us to have a more equitable offer for the whole of Leicester, Leicestershire and Rutland, which is what we need to do. I can't see anybody wanting to come in and add to that, so I'm going to keep going. Jack again, thank you. Surely we've had more midwife-led units over the county. We'll run the risk of having some underuse and some overuse. And again, some women and families will have to travel excessive distances. We're a hard-working family, but we don't have the funds to travel over to Melton. Yeah, okay, thank you for that point, Jack. Glyn, it works both ways. Yes, it does, which is why the travel impact access. Okay, these are more comments than questions, so I'm still running through them. In your response to the issues of whether it's a financial consideration to have one centre and not multiple centres, says it all. So
can I just come in on that, Carolyn? Because
yeah,
I think we do have a responsibility to spend the public money as best we can to. Sorry, I'm Andrew Furlong, I'm the medical director. So what we're trying to do with the plans that we've got for the acute and maternity hospitals in Leicester is to try and bring services together where it makes clinical sense for them to come together, but also to try and ensure that we get great outcomes for patients, that it makes sense for clinicians in terms of the way that we have staff located and the services located, but also try to address the long-standing issues that we've had with staffing. So you've heard about the difficulty that we have from time to time of staffing 2 units, the difficulty that we have in terms of running 2 neonatal units, and that's something that you need to be aware that the CQC has raised serious concerns about in the past. In terms of the fragility of those services and feeling that those models are not in the long term and not sustainable. So we're trying to address a number of these things, but we also want to try and we fully recognise that a standalone midwifery birthing unit is something that people want, and we want to be able to offer that to more people. So there is something about equity we talked about, but we also can't get away from the fact that you know, if money was no object, you could spend and spend and spend on healthcare, and in some countries they do. So in America, they spend 20% of their GDP on healthcare, but in this country, we spend about 10% of our GDP on healthcare. So we have to use that as effectively and as efficiently as we can. And we all have a public duty, all of us who work within health, to try and get the best outcomes for the money that's available for us, that serves the most people and provides equity of service for as many people as possible. And that's the harsh reality in which we work.
Thank you, Andrew. I think that's a really important message to state. I'm going back to the chat. There's a lot of chat in the chat now, and probably between yourselves as much as anything else, as in terms of us. Some key messages coming out about how, really promoting, how are we promoting the St Mary's birthing unit, and just making sure that is. But a question from Rupal Shah. How many women booked into the St Mary's birthing unit have had to transfer to the general or the LRI? I've lost Ian on my screen, but I think that's probably one for Ian.
I'm back.
Oh,
I did drop out for a couple of minutes, unfortunately. I think I indicated before that something around 40% of women who plan initially to go to St Mary's to have their baby need transfer during pregnancy, and about half of those actually in labour. So if 170 women, you can do the numbers, if 170 women actually have their baby, then about 300 will book and about 130 will transfer during the pregnancy, and about 60 of them will transfer in labour. Now, there is an interesting element to that, which is that there is a misunderstanding about what can be provided at St Mary's in terms of support for labour and delivery. And we have had occasions, a number of occasions, where women have expected that there's going to be very easy, an easy ability to transfer from St Mary's to one of the two maternity units, either at the Royal or the General. And problems have occurred in transfer because it's taken longer, because of the unavailability of ambulances or whatever. And the women haven't clearly understood that that was a significant likelihood, and that it may cause problems should it be necessary. And we don't tell people that, it's a major risk or anything like that, because it isn't. Because the best available research, which is the birthplace study, demonstrates that actually it isn't a major risk to choose to have your baby in a standalone birth centre or at home, and the outcomes are the same. But the fact is that women, when they understand that they may have to transfer in labour, will very often choose not to have their baby at St Mary's or at home for that matter. And it would be irresponsible for us to not tell them that it might be necessary when 1 in 5 women do need to transfer in labour.
okay, thank you, Ian. Another question then from Glyn Cartwright about our staff, and it says, Glyn says, why have staff at St Mary's Birthing Centre been expressly banned from participating in public social media debate on the future of the birthing centre? Elaine, can I come to you on that one, please? Your staff.
Yes, that's fine. So they have been invited on the staff consultations, and the public consultations are free to join whenever they like. We have got a social media policy that's for all staff in UHL, not specifically St Mary's staff. So it applies to everybody, and it's just that they are employees of UHL. So, to join in a debate in a sensible manner is quite acceptable. So, they're just probably following the policy. None of us, I certainly haven't, and the matron certainly hasn't been and said, absolutely, you are banned from making any comments about St Mary's Birth Centre. We went out to them and spoke to them before the public consultation began, and we have offered to go out to them again whenever they need us to be there. So I'm not sure what you mean. If you mean by commenting on the Facebook page or things like that, yeah, that is in our social media policy that, you know, we're not supposed to join things like that, but they have got, you know, certainly got opportunity to give opinion on these public consultations.
Okay, thank you, Elaine. I think it's important that we support staff to be involved where they can, but absolutely acknowledging our policies and procedures that they need to follow. I'm just still scrolling down the chat. There's a lot of comment in there. We will absolutely be taking note of the comments that are being made here. Okay. Glyn, there are currently 7 non-medical staff at St Mary's Birthing Centre. What will happen to those staff if St Mary's closes? If they are to be made redundant, what will be the cost of redundancy? Ian, do you want to pick that up from a medical staff perspective?
Yeah, we're not expecting to make any staff redundant in this process. So all staff will be given the opportunity to work in the reconfigured services. And what we would hope is that our staff at St Mary's will either choose to continue working in roles that will be available in community midwifery and other support up in the northeastern part of the county, or alternatively consider coming down to work in the new standalone birth centre, or indeed in the new co-located services at the Royal Infirmary. But we're not anticipating making staff redundant.
It's probably also worth saying, and Caroline might want to say some more on this, is that we are actively talking with Melton Council about how we enhance the services that are left behind at Melton Hospital. So there is no intention to close Melton Hospital, and in fact we're looking to put additional services there in the future. Just that what we're specifically talking about tonight is the birthing unit, but the Melton Hospital will still remain, and for those people that there will be opportunities for employment within Melton Hospital if transport is difficult for them in terms of moving jobs.
I think, Andrew, you've probably said everything I need to say. It is important that whilst we have been saying through the whole of these engagement events that the questions around the community hospitals aren't covered by this, and we will be coming back out to people to talk about our expectation for community hospitals. Melton, it's one of our newest sites. Terms of the ward base there, but also we're keen to make use of the non-ward areas as well. So really committed to doing that, and I think it in terms of what happens with the specific site of the St Mary's Birthing Centre, that'll all be picked up in terms of what happens with the whole site of Melton completely. Okay, I'm going to go to somebody who's got their hand up. I can't see who it is at the moment, but oh, it's Elizabeth Warren. You've got your hand up again. You might be on mute, Elizabeth, because I can't hear you. No, I'm sorry, I still can't hear you. Can anybody else from my Andrew?
I didn't switch it on. I've switched it on now. Sorry about that. Right, and Ian Scudamore mentioned research just now, and I've been reading research which has convinced me that very large hospitals, such as the one that's going to be established in Leicester, it will be a mega hospital, one of the biggest in the country, that they are very, very poor when it comes to outcomes for mothers. And there are a lot more complaints from women, apparently, and I wonder whether, in fact, and they're more expensive to run as well, apparently. And I wondered whether you have actually read the research that I've read, because if you haven't, I'd like you to read it. I don't know what's happened.
You'll be Caroline.
Sorry, I keep trying not to put myself on mute. Ian, did you want to respond to that?
I suspect I haven't read the research that you have, Liz, and I'd be very happy to read it if you.
I'd be very happy to send it to you.
That would be very, very kind of you. We're very aware of the potential risks associated with a single maternity unit, and it's interesting this because for a long time I was seen as an apologist for Leicester General Hospital, because I was appointed as a consultant at Leicester General Hospital in 1997, as I said, and I've been determined to make sure that the services that are provided at Leicester General Hospital are sustained and protected whilst that unit still exists. And for a long time, I was determined that we should try and maintain 2 maternity services, because to some degree, I would certainly agree with you that I think it would be nice to give women, for lots of reasons, to give women the choice of one unit or the other, to have one out of the centre of town and one in the centre of town. I think in many respects having units of 4,500 and 5,500 is better in terms of the identity of the staff that work in those different organisations and so on. Ultimately, though, we have a very serious problem in Leicester, which is that the configuration of the 3 acute sites as such is just not sustainable for the long term. And that's part of the video, and it's part of the overall reconfiguration of services in Leicester. And what that does, I'm afraid, Liz, is it creates a situation where the unit at Leicester General is just not able to be supported safely. You cannot have a unit delivering 4,300, 4,500 women with mixed acute, what we call acuity, mixed complexity, without having proper acute support services on site. You just can't have it. It would be extremely unsafe. So in those circumstances, we looked at a number of different things. Would it be possible for us to expand services at the Royal Infirmary, and so that we could maybe do 8,500 at the Royal and a couple of thousand at the General? Would it be possible for us to have a midwifery unit, effectively a low risk unit, delivering 2,000 babies a year at the General? And unfortunately, it just isn't realistic. And those were options that we looked at as part of the broader option appraisals that we carried out in the noughties that I referred to earlier. So I very reluctantly, I have to say, ultimately accepted that the only realistic option for sustainable long-term maternity services in Leicester are those that we're proposing and that we're consulting on now. Now, it's up to us then to make sure that we address concerns about it being a mega unit. And I'm as concerned as you are about the potential for it to be a mega unit and the issues around that. You know, people talk about, they use phrases like baby factory, and that is something that we absolutely must avoid. And we must design this in such a way that it doesn't feel like that, and that we do address the concerns that you're raising.
Okay, thank you, Ian. I'm going to go back to questions in the chat. Who's this one? Glyn Cartwright. You've put in that it's been stated that there'll be a new birthing unit at the GH, that's the General Hospital, I presume, not the Glenfield. Why is it necessary to close one and open another? I think we've talked about that in terms of equity of access across the whole of the county, but I'm not sure we've asked the question about the General won't be providing postnatal care. Where will postnatal care be available? If new postnatal care facilities have to be set up either at home or within hospital, will that set up? Will the setup costs be an ongoing cost, be an issue?
So, Karen, I think Elaine did answer that actually in her response to the previous question about postnatal care. Insofar as the model for providing postnatal care in the new maternity hospital at the Royal won't be any different from the model that we have now in the 2 units at the General and the Royal. And the model for the new birth centre will be based on women staying in the room that they had the baby for a period of time, which we're hoping will be up to 24 hours. and then providing a team-based support in the community when women go home. And that's the model that is being nationally supported through maternity transformation and better births. That's the approach that we need to be taking.
Thanks, Ian. I think that answers the next bit about how will mums to be and mums access antenatal and postnatal appointments. That it'll be about services in the community rather than bringing mums into Leicester for those appointments. That's and we really want to have the appointments where the mums are, and focus on that. Okay. Finally worked out how to make the chat bigger so I can see it a bit better now. So I think we've talked about why it's a proposal, the new unit, because we need to look at about feasibility. I'm looking for a question. Oh, okay. Yeah, another question about postnatal care. Carol Hopkinson, your point about Hinchinbrook and Addenbrooks being like mini towns. Ian picked this up in his previous response in terms of, this definitely the design of the building that we want to not make it like mini towns and make it distressing for patients who are already under distress. And the design, and Darren, do you want to talk to us about the design of the building and how we might influence that by mums to be and people who have used maternity services in the past?
Okay, thank you, Carolyn, and good evening, everybody. I'm Darren Kerr, Director of Estates and Facilities and Capital Development for the Trust. It's actually going to be my responsibility to deliver all of this. So it's absolutely in our interest to make sure that we maximise input to the design, which we're doing at the moment, to make sure that this is modern healthcare. And the thing we have to recognise is in all of our plans, for anybody who's spent any time on our sites, we have a range of condition of estate. We have a lot of our estate. In fact, the bulk of our estate is over 40 years old. So by far the greatest majority of our estate is quite, in some cases, quite tired. We know that there is a wealth of knowledge out there, and a number of members of the public tonight have referred to research. We know there's a lot of research out there about what we refer to as the healing environment and how important it is for us to maximise light, to look at sustainability issues, to look at space, which is what's been mentioned again this evening, and the benefits that has to how patients feel when they come into our environment. So we're going to be looking at obviously what the current standards are, and there are specific standards around buildings in healthcare, referred to as health building nodes. We'll be looking at things like sustainability and social values, which are very key factors in what we're going to be doing and designing. But most importantly, we're going to be engaging through various mediums, including things like virtual technology, so that people can actually virtually see the patient pathway from when they enter our buildings right to the kind of birthing room and into the ward environment that people are going to be staying in. And not only will our clinical staff get an opportunity to directly affect what that looks like, and using the wealth of experience that our people have around this, but also some of our patient and public groups will be able to see these and hopefully influence that to address what Ian said. We don't want this to look like, a scary environment. We tend to make health environments very sterile almost in terms of how they feel. But if anybody's been into any new units recently and see the stark difference there is in those compared to what we've got in our estate, then I'm sure everybody will be able to see that difference and realise that that's what we want for our patients, our public, our staff, our visitors, is the best environments we can provide across Leicester, Leicestershire and Rutland. And that's what we'll achieve with this new build. Thanks, Karen.
Thanks. Don't go anywhere because there are a couple of more questions I think you can answer. In terms of adequate and easy free parking on site, there's a question as to whether or not there'll be that, but also the bit of a comment about the traffic around on the ring road increasing, what we might be doing to support, particularly that road around the Royal. I know you've got some thoughts about that as well.
Yeah, Justin mentioned earlier all of the stuff around the traffic and travel planning and the traffic calming exercises that will be undertaken collaboratively with the City Council as well. So we're working really closely with the City Council and their traffic team, and highways particularly are very conscious of us overloading the physical access to some of our sites. Well, let's be honest, car parking at the Royal has been extremely challenging. Is when I joined the trust just over 5 years ago, and the first challenge I had was to reduce the car parking congestion in Havelock Street. So I built a new multi-storey car park to help in that regard. But we're very, very conscious of it in terms of car parking. We're very conscious of the dynamic change that it's going to bring to the Royal site, with maternity services being on the Royal, in terms of more areas for patients to and for visitors to that area to have drop-off sites outside of the unit before then having to go off and park the car for a period of time. So we're going to be reflecting all of that in how we do car parking going forward. It is a challenge. It's a challenge part of the city in terms of its the sort of carbon in the atmosphere in that area. So again, Justin mentioned earlier about how we're going to be looking at different access opportunities, working collaboratively with Go Travel and City Council all around access. Free car parking is a very political issue at the moment in the NHS, and one I wish we really did have an answer to. But we do have already lots and lots of concessions available for people who who come to our site for whether it's maternity services or any of our clinical services. And as a minimum, we'll be continuing with the arrangements that exist already at areas like the general. So we'll do that as an absolute minimum. But car parking is an issue that I only wish, Caroline, I did have the answers to the solution. I spend probably a disproportionate amount of my time trying to think about solutions for car parking. But it is something which is very topical issue at the moment, and something I think we'd all love to see free across the NHS if we can find a mechanism to deliver it.
Thank you, Darren. There's quite a bit in the chat about listening to mums and being able to listen. Mel Thwaites, I wonder if you might want to come in and talk to us about how we're seeking to hear the patient voice and the voice of mums and dads alike.
Yes, thanks, Caroline. Yeah, we've recently set up, well, I say recently, it's now been going for probably 2 years, a new forum called the Maternity Voices Partnership. And that's where we have the opportunity to listen to women and dads about what they want, what services they need, and what they think of the current services. And we've actually utilised this group to test out our ideas and views and get their feedbacks. In terms of the mix of the group, we have representation from all 3 parts of Leicestershire. We have some dads and obviously lots of moms, and the age range is predominantly women who have recently had a baby or moms that actually are pregnant at the moment. We also go out and do lots of engagement with various groups and utilise existing forums to go out and test our ideas and views.
Thank you, Mel. And I'm going to come on to talk, before we close tonight, I'm going to talk more about how we want to hear, get the message out to other people and hear the feedback from a wide range of people through the mechanisms that we've got. But so we will come back to that point. Kathy Reynolds, you put a question in the chat around the ranking for Leicester Hospital Care. Ian, I think, is going to pick up that one.
Yeah, I don't quite understand it. The maternity at the Royal is not the 4th largest in England. 5,500 deliveries makes it big, but not the 4th largest. I don't know exactly where it ranks. Overall, our maternity services in Leicester at the moment, in terms of trusts, are the 3rd largest in the country that I'm aware of. Barts is bigger, Manchester is bigger, and in fact I think Birmingham might be bigger now, but they're on 3 sites and we're on 2. So the Royal is big, but it's not as big as Sheffield, it's not as big as Liverpool, it's not as big as Plymouth, I don't think. There are a number of other bigger services around the country, and then there are at the Royal. The General, you're right, is a big unit as well, and at 4,300. I don't quite understand, why is UHL just poor at managing staff, or is 50% of maternity offering poor services? I don't quite understand that. I mean, the difficulty is dealing with peaks and troughs, and the difficulty is being able to run 2 rotas across 2 separate sites, particularly with medical staff, for example, because it means we have to have resident medical staff on both sites. And if we were on one site, we wouldn't need to have so many doctors across that we have to have across 2 sites, and yet we'd be able to provide services that were of equal or better safety. So I'm a little bit puzzled by the question, I'm afraid, Caroline.
Okay, Kathy, if that doesn't cover the question, if you wanted to pop it in the chat again to repeat, please do that. Okay, another question from Kathy around the patient groups to influence design. What is the age and gender profile of our patient group? Mel, do you want to come back on that one?
Yeah, I think, as I said, we have the age is predominantly women who either are pregnant or have recently had a baby, and we have gender is, we have some men, we have a couple of dads who are actively involved, but it is predominantly women. In terms of makeup, we have representation from all ethnic groups, from City, from Rutland, from Melton, from all over Leicestershire. We have really good representation.
Thanks, Mel. I think that answers Helen Cliff's question about as well, about whether there's an opportunity for conserved service users in Melton area to feed into the new design unit. Yes, it would. Yes, Mel was talking about taking people from across a wide section of our community, definitely. Apologies if I'm summarising the questions. The questions are in the chat, so if people would prefer to ask them rather than me summarising them, then that's absolutely fine. Becca has put that sounds like you've made your decision already. So, is St Mary's birthing unit going to be relocated? Are any of these consultations and workshops going to influence our decision? So I think it's important to say what the purpose of consultation is. The purpose of consultation is to be able to hear the views of our population, to understand how it impacts on them, and we need to make sure that we hear that from a wide proportion of our population. And in terms of the of whether it will influence that feedback, when we look at it and we analyse it, we need to look at it to see what it's saying. We will have an independent organisation look at that feedback, so we're not going to only take the bits of it that we want to hear. We'll get it, everything, and that feedback will help us think about the next steps. In terms of, is it a vote? I think I need to say quite clearly, you know, that consultation is consultation. It's about understanding and listening and hearing, and the more people can get their views across to us, the better. So I've just noticed the time. We've got about 6 minutes left. I'm not sure whether I'm near the end of the questions yet. So if there's anything particularly that any colleagues of mine think that we haven't covered in the rest of the questions, if somebody could give me the heads up, that would be great. Oh, we've got a question here about what budget has been set aside for providing community services and what will those services look like. That may be something I think that we're going to have to come back to on that one in terms of what our provision for community services will look like, particularly from a midwifery perspective. Elaine, I'm not sure whether or not you've got any headline.
Yeah, I can just answer that. We've already got a really extensive community midwifery service across LLR. We've got 109 midwives, that's full-time midwives that work in the community, which is about 135 actual people. They all work, there's about 10 teams of them in the community at present, covering all areas of LLR. So we've already got those midwives in there, and we will be looking at expanding some of the community teams and the maternity support work teams to ensure there's breastfeeding drop-in clinics and postnatal clinics as well, to help support areas of the county and how to reach groups of women. So we won't have to put a whole lot more money into the community midwifery service. It's already well established and works really well.
Thanks, Elaine, for that one. Glenn, you're quite right. Yeah, you have posted this question 3 times now. I think we have responded to the rationale for the potential the fact that the new birthing unit is a potential proposal, and that we need to test the feasibility of that and in terms of uptake. I acknowledged the position about community hospitals years ago, and we will come back to that issue around community hospitals and talk to members of the public about what those services need to look like. But it's just not part of this consultation. That's the message that I gave earlier. So I've just sort of just let me check if we've got anything else.
Caroline,
yeah,
I think the question that DC has put up at 8:15 is relevant and important. Women being urged to stay at home for longer before heading to hospital to give birth. How will this approach work with having the main site at the Royal Infirmary? Yeah, I mean, I think that's very important. And the way we work at the moment is that when women ring in, we take into account where they live in terms of advising them when they should attend whichever place that they're planning to have their baby. And so, you know, if a woman rings in from Loughborough and thinks that she may be in labour, then we would probably want to see her sooner than if she lives around the corner from Leicester General or from the Royal Infirmary. And those are things that absolutely will need to be taken into account with the new unit.
Thank you, Ian.
Elaine may want to comment on that. I don't know.
No, I've nothing to add. You said that very eloquently. Thank you.
Okay, thank you. It is 2 minutes before the end of the session, and there are some questions that we haven't come back to. If we can do that offline, I just need the heads up from my comms colleagues, just to say that that's a possibility. Mel, is that something that we could do, Mel Shilton?
Sorry, can you repeat that, Caroline?
Sorry, I'm just checking. We're just about at the end, and there are questions that we haven't quite answered. Are we able to add them to our Q&A and put the responses on our website?
Yeah, that's fine. Yeah.
Yep. Perfect. Thank you. Okay, so if we can go to just back to the slide pack. Again, I can't see the slides, so if you just let me know when they're up. Okay.
Yeah.
Is that slide 5?
It is.
Thank you. So just to reiterate where the information is held for those of you that may not know, the details of the consultation are on our website. That's www.betterhospitalsleicester.nhs.uk. And as I've said during this presentation, we do want to really encourage people to fill in those questionnaires. So please do that and encourage others to fill them in as well. And if you need a hard copy of those, if people aren't comfortable about doing those online, then let us know and we can get something else to you. And I think the final slide just gives us information of our social media pages as well, where people might want to post things as well. So it's 8:30. I'd just like to say thank you so much for taking part in this evening's discussion. I'm going to go and have a cup of tea because I think I've taught myself hoarse this evening. But thank you to Ian and Elaine particularly, and Andrew, Darren and Justin and Mel for contributing to the feedback. And I hope you're going away with more information that you had when you started. So thank you very much, everybody.